So my title of my talk, I've taken the liberty of changing. Basically what we're looking for, this is a quest. We want to be able to quantitate the extent of brain injury, and then we want to be able to treat it. And so I'm going to talk a little bit about different aspects of coming together in search of that quest. These are my disclosures. Most of them were already mentioned. The ones that are really relevant to this talk are Integra, because they do make monitors for brain function. Oculogica also does, Abbott does. These companies all make diagnostics for brain injury. And so those are relevant. As you know, brain injury is the single greatest cause of morbidity and mortality in the United States for people under the age of 35. So it's a huge problem. It's not something that's gotten less over time. It's actually more recognized. And so you would think that with a problem this great, that there would be phenomenal diagnostics and we would have an excellent handle on it. And the reality is that we're nowhere near that. These are the states with the highest rates of brain injury related fatalities. And what we see here is that the states that have the highest fatality rate are the ones with the most rural population. Wyoming, Montana, Louisiana, Nevada, they're all very rural areas. Well, why is that? Basically, what it means is that if you don't get treated for brain injury, you do really, really badly. If you do get treated for brain injury, you do much better. So Connecticut, Massachusetts, New York, District of Columbia, nearly 100% of the population lives close to a level 1 trauma center and they're getting treated. And this is what that map looks like of the United States. So what does that mean? That means we need to be able to get these patients to the hospital so that we can treat them. Well, how are we treating them? What are our diagnostics? What are we doing to get these people better? Well, the first thing you sort of have to ask is, well, how are we measuring the vital function of the brain, right? Well, what's a vital sign? A vital sign is something that indicates whether or not someone's alive, right? So it's things like heart rate, body temperature, blood pressure, respiratory rate. All of those things tell us, is a person alive or are they dead, right? Well, where's the vital sign that tells you if the brain is functioning, right? There isn't one. Why is there no vital sign for brain function? Well, it's because the brain is much, much more complicated than the rest of the organs, right? With something like the heart, it's relatively easy to measure heart function because you can measure, I always joke that you can do it in 2 letters, ejection fraction, right? But it's heart rate and blood pressure. That's a very good, easy, rough measure of heart function. Well, where's our good, easy, rough measure for brain function? And that's why we're going to be looking at something like ICP or intracranial pressure. What happens when a patient with a brain injury comes into the hospital? You have a certain amount of information, right? You can get a history. So you can tell, was it a single car accident? A single car accident is an impaired driver until proven otherwise. Restrained versus unrestrained. An unrestrained driver is going to do worse. Helmeted versus not, that's an obvious one. Duration of extrication. Were there things that complicated the brain injury? So was it not just an impact, but being stuck in a car with a lack of oxygen? Because an anoxic brain injury is a completely different kind of brain injury than a traumatic brain injury, a purely impact brain injury. So these are things that we have to know. Do we have a vital sign that can measure these things? That's what we need to ask ourselves. What meds have already been given to the patient? All the meds affect the central nervous system. Where was the patient intubated? If they were intubated in the field, that's a bad sign. Hemodynamic stability is important because if you don't have blood pressure, you're not filling your brain with blood. And if you're not giving your brain blood, you're not giving your brain oxygen. So that's incredibly important. How are the other victims of the accident? And do we have a history on the patient? So what's the first thing that you notice when someone has a brain injury? So if you were to walk into a room and there were to be a brain injured person lying on the floor, how are you going to know that that person has a brain injury? Assume that there are no obvious signs of trauma, right? Well, you're going to check for things like blood pressure and heart rate and respiratory rate. And those things are all going to be abnormal. So these vital signs do tell us something. Who figured that out? That was Harvey Cushing, right? So what happens when someone has a brain injury? Often they have high blood pressure. Why do they have high blood pressure? Because they're trying to get blood to their brain. There's an autoregulatory system that increases the blood pressure when the intracranial pressure is high, so that you deliberately perfuse the brain and give it oxygen. It's a reflex. Bradycardia. Why does bradycardia happen? That's a function that comes from the brainstem, right? The brainstem controls the heart rate. Irregular respirations, same thing. So what is your first clue that someone has a brain injury or a stroke or any other neurologic injury? You're looking for hypertension, bradycardia, irregular respirations. If you walked in the room and the patient was unconscious and lying on the floor and they had a low blood pressure, that would more likely point to something like a cardiac problem. So there's your first clue, your first vital sign. What else do you see with brain injury? You see a failure of cerebral autoregulation. So what that means is that in a normal person, there is a range of blood pressure over which the amount of cerebral blood flow remains constant. And when someone has a brain injury or stroke, that ability to autoregulate is impaired, and the cerebral blood flow becomes proportional to the mean arterial pressure. So what happens is, instead of having this plateau of blood pressures that are pretty much normal, you've got an area where your blood pressure is basically collinear with your cerebral blood flow. So whatever your blood pressure is, that's what your cerebral blood flow is. And that's a failure of autoregulation. So you can see that that line becomes linear. So what's next? So you've got your patient who's come into the trauma bay. They're lying there unconscious. How do you communicate what's wrong with them? Well, the way that this has been done for 30 or 40 years, and you guys may have seen or heard this, is the Glasgow Coma scale, right? So you've got your eye opening, your motor response, and your verbal response. You get 3 points just for showing up, even if you're dead, right? Is this a vital sign? Does this tell us about brain function? Yes, this does tell us about brain function, but what it tells us is the patient's exam at that time. And the problem with GCS is that you can have a huge spectrum of pathology at any given GCS, some of which has a very positive prognosis and some of which has a very negative prognosis. So you can have, suppose you have 2 or 3 different patients all with a GCS of 15. One of them may have a potentially progressive fatal brain injury if they have a rapidly expanding epidural hematoma, right? A blood clot on the surface of the brain. So is this a vital sign that tells us about brain function? Yes, but it's not necessarily going to give us an accurate way to prognosticate. What it is a way of conveying what the patient's examination is very rapidly. So if someone says GCS 15, I know I can walk relatively slowly down to the trauma bay, even though they might have an expanding epidural hematoma that I have to deal with. Whereas if they say GCS 3, then I know that that patient's just shown up, but they could be, you know, anything. They actually could recover fully, but they may potentially have a very severe brain injury. So GCS is a way of rapidly communicating exam, but it's not necessarily going to tell you whether or not the patient has a particular pathophysiology. So what do? You're in the trauma bay. The very first thing that you do, usually after you examine the patient, is you get after the brief exam, is you get a CT scan, right? And a CT scan does give you quite a bit of information. You know, you can determine to some extent laterality of the brain injury just by exam, right? The blown pupil will be on the side of the lesion, but a CT scan is usually the definitive step. And if the patient is not stable enough for a CT scan, usually they're not stable enough for a neurosurgical intervention. Your basic anatomy, right? So when you look at the CT scan, if you look at nothing else, the first thing you try and figure out is the brain symmetric? Are the structures that are supposed to be in the midline, right? So you've got, I don't know if you guys can see my mouse, but you've basically got your falx going down the midline. You've got your third ventricle in the midline. You've got your aqueduct in the midline. You basically have this structure that looks, it's essentially your quadrigeminal cistern, because you've got your superior and inferior colliculi right here. And this looks like a bat, right? If you picture sort of Batman, if you can see Batman, that means that the brainstem is less likely to be compressed. So, you know, basic anatomy, that's the first thing that you're going to look for when you look at a CT scan in the emergency department. What kinds of problems can you see on the imaging? So this is a coronal image. The last one was an axial image. And what you see is you can see different areas of herniation. On this particular scan, you can see subfalcian herniation. You can see uncal herniation. My mouse is not showing up. You can see uncal herniation in B. You can see transtentorial herniation in C. External herniation. So if someone has a open depressed skull fracture, you may see something like that. And tonsillar herniations when the cerebellar tonsils go down. Your clinical exam, as I mentioned, the pupils tell you a lot. A conjugate gaze deviation, you look towards destruction and away from irritation. Other cranial nerves, the corneal reflexes, tells you about cranial nerves 5 and 7. 5 is sensation, 7 is movement, right? You blink. Your gag, you've got posturing, and then you look for obvious signs of head injury, and sometimes they're very subtle. I had a patient just the other day who'd been shot in the head, and the entry wound was so small, it was basically completely missed on the preliminary screen. Conjugate gaze deviation, again, you can differentiate where the lesion is just on exam. If the lesion comes from the frontal eye fields or from the brainstem, you're going to have a different response to the doll's eyes. Okay, so if it's frontal, the eyes are going to move when the head is moved, just like a doll. And if it's from the brainstem, the eyes stay put. Other things that you can tell right away in the trauma bay, you can tell pupillary constriction, right? So if both pupils constrict, that's a good thing. That means cranial nerves 2, which is the afferent of that, and cranial nerves 3 are both working. When you get a loss of consensual pupillary light reflex, that means that you've got a failed third nerve. When you've got a loss of the direct pupillary light reflex, that means you have a failed afferent. You have a failed second nerve. Posturing, the easiest way to think about it is that decorticate posturing comes higher up through the internal capsule, decerebrate comes through the brainstem. And so you can definitely see posturing in these patients. Blood flow, pupillary response, and outcomes. So if you have non-reactive pupils, which is bilateral and BNR, bilateral non-reactive pupils, you're more likely to have a poor outcome. If you have reactive pupils, you're more likely to have a good outcome. So are any of these things vital signs? Do any of these things tell us, about brain function? No, but they give us some idea of how we can classify the nature of injury. And what is our current classification scheme? So if you were to Google, which, everyone Googles on Wikipedia, you look it up, how do you classify the nature of brain injury, right? It's mild, moderate, and severe. So mild is a GCS 13 to 15, and short duration of amnesia, short duration of loss of consciousness. And severe is a lower GCS, greater amnesia, longer loss of consciousness. What is the problem with this? Well, the problem with this is that it's not true. You can have patients who present with what appears to be a mild brain injury who actually have permanent and persistent consequence with chronic effects. And you can have patients who present with severe injury or with what is classified as a severe injury who go on to make a full recovery. The problem is that loss of consciousness can occur for many reasons. And in our patients, 50% at some centers will be intoxicated. Many patients have polytrauma. You can lose consciousness not just from a brain injury. You can lose consciousness from a transient respiratory or cardiac arrest. What does that do? That can often cause an anoxic brain injury, but there may not necessarily be a traumatic component to that. A lack of loss of consciousness does not necessarily equate with a milder injury. Here's an example. This is a 37-year-old woman who fell 2 weeks prior. She had no headache or anything at that time. She subsequently developed a headache and speech difficulty, went to the emergency department 2 weeks after the fall, and was diagnosed with this, which could potentially become a progressively fatal injury if she had not sought treatment. So here you have someone who literally does not meet the definition of mild, moderate, or severe injury, but potentially has what could be a fatal injury if it were untreated. So we know that the current classification scheme for brain injury fails. Why is it so hard? Well, the problem is that no two brain injuries are the same. You can have someone who's hit in the head and they have different things wrong with them, and similar symptoms can have multiple causes. Where does ICP play into this? Where does elevated intracranial pressure play into this? Well, that's what we're going to talk about in this lecture. Basically, some of these conditions may manifest very similarly to a brain injury, but they don't necessarily have an elevated ICP. Others of these conditions do have an elevated ICP. So does ICP tell us everything about brain injury? No. But does it give us a lot of information about potentially fatal brain injury? Yes. So you can have a person who's hit in the head, 17 to 20% are going to have a comorbid cervical spine injury. Some are going to have vestibular dysfunction. You can have a shearing of the hypothalamic axis to the pituitary, and then you can have a delayed endocrine dysfunction. You can have cortical spreading depression, which we know is caused by multiple things, including focal and non-focal brain injury. And then you can have the obvious, the scalp injury, the skull injury that you see on the imaging. This you see on exam, this you see on imaging. You can have blood clot on the surface of the brain, outside the dura, inside the dura, in the subarachnoid space or in the interventricular space. And all of those things, just to have hemorrhage anywhere in the brain has consequences, because the breakdown products of the blood include iron, and that's toxic to the brain. It causes apoptosis. Does that elevate ICP? Sometimes, sometimes not, right? If you have a rapidly expanding lesion in the brain, you're going to have an elevated ICP. Is it possible to have a small amount of subarachnoid hemorrhage and not have an elevated ICP? Yes. So ICP does give you some information, but not everything. Diffuse axonal injury. Here's an injury that may not necessarily elevate ICP in all cases. Anoxic brain injury classically does not elevate ICP. So you can have a patient with a very poor prognosis that doesn't have an elevated intracranial pressure. Ultimately, neither imaging nor loss of consciousness or physical exam tell the whole story. There are so many different types of brain injury. There's the brain injury that you see when you look at the imaging. There's the brain injury that is associated with loss of consciousness. There may be loss of consciousness without brain injury. And then there's the elephant in the room, which is the physiologic brain injury that is composed of multiple different pathophysiologies that are all completely different in terms of their prognostics, and not necessarily always associated with the same manifestations clinically. So some patients may have elevated ICP and some patients may not. So what correlates with improved outcome after brain injury? Obviously younger age and being less sick, better clinical examination. There's some EEG parameters, the integrity of the motor and sensory tracts, being cared for in a non-rural setting, dedicated neuro-ICU, volume of patients treated, whether or not you have a neurointensivist, normal glycemia, and now we're going to get to the crux of this ICP or brain oxygen monitoring, and sedation and paralysis. So let's go to the next slide. So let's talk a little bit about ICP. So the purpose, so if you walk into the room and you see a patient who's lying on the ground unconscious, why do you do, if they suppose they have no pulse or something like that, why do you do chest compressions? The purpose of chest compressions is to provide oxygen to the brain. That's the only reason that you're doing it. You want to increase the mean arterial pressure so that you can overcome whatever intracranial pressure there is, so that you can maintain cerebral perfusion pressure. You can give oxygen to the brain. The purpose of all of medicine, the rest of what all the other doctors in the entire hospital do, is maintaining the milieu for the brain. So what is important is you keep your blood pressure up so that you can perfuse your brain, right? You keep your lungs respirating so that you can provide oxygen to the brain. That's really the bottom line. So you have monitors that measure ICP, intracranial pressure, where other monitors measure brain tissue oxygenation. The normal brain tissue oxygenation is greater than 25. The ischemic penumbra is 15 to 25. So let's talk a little bit about ICP. Maybe ICP would be a nice vital sign, right? There are good things about it. It's an integer. It's like heart rate and respiratory rate. We like integers. They're easy for us to understand. We can set a treatment threshold, right? So it's very easy. You tell the nurse, you leave a note at the bedside, an order saying, please call me if the ICP goes above 15, right? And then she knows what to do. She'll call you, right? What are the cons about ICP? Well, the cons about ICP are that there are patient-specific thresholds. So what we know is that some patients, when they're upright, for example, there are papers by someone named Euler who's in Europe, where they've monitored ICP in patients after they've had, for example, tumor removals or other surgeries. And what they found is that your ICP can even be negative when you're standing upright. And different people live at different levels of ICP. And what does that mean? That means that when someone has a brain injury, they live at different levels of ICP. And so one person may be abnormal at an ICP of 10, whereas another person could have an ICP of 15 and not necessarily have consequences. It depends on what your, how much brain atrophy you have, how much loculation you have, how many arachnoid granulations you have. There's so many different factors. We do know now that ICP can be different when it's measured in different parts of the brain. So not only do you have different thresholds that are abnormal, but you also have different levels in different areas of the brain. So what does this mean? This means that ICP is probably not a perfect measure. There have been 30 trials that have not shown, that have not met outcomes goals that were based on treating on the basis of ICP. And the ones that are really sort of standing out here are the one, there was one called Best Trip, where basically there was a country in South America, I believe, where they compared ICP monitoring versus no ICP monitoring, and they found that there was no difference in outcome. Another clinical trial that showed that measuring ICP didn't change outcome was the Rescue ICP trial. So why do we measure ICP? Why do we think that it might be a good indicator of what's going on in the brain? And I'm going to talk a little bit about that. So how are we doing with ICP as our indicator of treatment threshold? If you sum a whole bunch of trials, so you look at 10 trials that have an intervention, and you compare the intervention group to the control group, what you see is there's not a dramatic difference in outcome if you use ICP as an indicator of treatment threshold. So we need something a little more rigorous than just intracranial pressure. Well, what are the ideas? What are the candidates for other things that can help us and tell us a little bit more about what's going on in the head? Well, how about brain tissue oxygenation? So this is a paper that came out of Penn that basically showed that this was one of 4 papers that was published in the 90s, essentially suggesting that if you measure brain tissue oxygenation, you might have improved outcomes. So there was what I call a quest to identify a vital sign that was correlative with brain function, and that was the BOOST trial. So this is the BOOST set of investigators. Some of you guys probably recognize some of the people here. Ramon Diaz-Arrastia is at Penn. David Okonkwo is at Pittsburgh. There are a number of other investigators that were involved in this study. This is what they published. So brain tissue oxygenation monitor is a little bit different. So this has been around for 20 years. It measures brain tissue oxygenation in one tiny little spot. So in other words, it tells you nothing about global brain tissue oxygenation. It tells you about brain tissue oxygenation in a millimeter cubed region. Unfortunately, there's no class 1 data that it improves outcome, but I will show you the data from the BOOST 2 trial. This is the BOOST 2 trial. These were the inclusion and exclusion criteria. These were how they put the patients into groups. So all the patients had brain tissue oxygenation monitors and ICP monitors. And then they were divided into groups depending on whether interventions were targeted based on brain tissue oxygenation or ICP. So in each group, brain interventions were targeted based on, for example, in type D, directed at both lowering ICP and increasing brain tissue oxygenation, or compare that to type A, where no interventions were directed at either of those. And these were the treatment algorithms. So actually, this has not changed dramatically. They're now doing BOOST 3, and some aspects of this have changed. There are new guidelines that just came out. It's actually, sorry, there's a new algorithm that just came out, published by the group organized in Seattle. But essentially, this is all algorithmic. So this is the kind of stuff that you should, if you're ever on call at night when you become a resident, you should have on a card somewhere, or you can pull up. These are your primary and secondary objectives of the trial. So your outcome measures would be a result in reduction of the fraction of time that brain oxygen levels are below the critical threshold of 20. And then your secondary outcome measures are adverse events, ability to treat, and non-futility. These were the demographics of the patients who were enrolled. Vast majority were men, and the vast majority were white. Many clinical trials have this limitation. So the TRACK TBI studies have this limitation. It seems that the patient populations that are studied are not representative of the patient populations that sustain brain injury in all cases, because we know that many minorities have high incidences of brain injury and are not represented in clinical trials. So that's a limitation of this study. These are the types of injuries and the mechanisms of injuries in BOOST 2. And what you see with BOOST 2 is that you're looking here at the total hypoxia burden if you base your treatment on ICP only versus ICP plus brain tissue oxygenation monitoring. And what you find, and this was the clinically significant outcome measure, is that if you base your treatment on both brain tissue oxygenation and ICP, you have less time where you're hypoxic. So the cumulative amount of time where you're hypoxic is less if you measure brain tissue oxygenation and treat it. Whereas if you only measure intracranial pressure, the amount of time that you're hypoxic is greater. The amount of time where you have an elevated ICP is not statistically significantly different. So what am I telling you? I'm telling you that you can have high intracranial pressure and still give oxygen to your brain, right? Because a certain percentage of patients did that. How do you do that? You increase PEEP, you increase FiO2, you increase hemoglobin, you give them Lasix so that their lungs oxygenate better. Somehow you increase the FiO2, you increase the PaO2 to get the patient oxygen, despite the fact that their intracranial pressure remains elevated. This is the secondary outcome, the non-futility measure. And what you see is a 10% reduction in the patients who end up dead if you're measuring both brain tissue oxygenation and ICP. So that, I think, is as good of an outcome as one could hope for. What this trial was criticized for was that the patients may survive, but they survive to be vegetative or have lower severe disability. So, you know, some people say that's a Pyrrhic victory because, you know, if you keep the patient alive, but they still end up heavily disabled, then, you know, that's not much of an advantage. I would argue that if you're going to save somebody, you want, if you're going to give somebody a shot, you should accept that there's a risk that they'll have a poor outcome, and you should explain that to the family. And you know, it's hard for the families to understand that, but you know, that's a decision that has to be made. My general rule of thumb is if I have a patient who's relatively young, I would say under the age of 30, I usually don't unless they have a clear anoxic component, I usually continue to do everything I can for that patient. When a patient has an anoxic injury or over the age of 65 or 70, then you start to have discussions about, you know, whether or not they would want to pursue aggressive management. This is, again, another way to look at the exact same data, secondary outcome, non-futility. So now we have two potential vital signs that tell us about brain injury, right? We've got ICP and we've got brain tissue oxygenation. What I would argue is neither of those gives us a very clear sense of the potential prognosis for brain injury. What am I saying? I'm saying maybe the brain is too complicated for a single vital sign, and what we actually need is a classification schema. So back in the old days, we used to have hypothesis-driven research, right, where pathophysiology was understanding-based. In the more modern era, we use things like machine learning. This is how cars drive themselves, right? So maybe we should be applying approaches generated from machine learning to brain injury. We use this for face recognition, right? So we've got face recognition software, and we can figure out exactly, you know, who's at the grocery store and how much money they spent last time they were there. So I would argue that we can start to take all of this information and use it to assess patients with brain injury. Well, what should we do first? Let's start with radiology. Let's use algorithmic ways of quantitating what's going on in a CT scan. We already have this technology. This is a paper that came out of a large group of collaborators at WashU, and basically they showed that you can quantitate the extent of cerebral edema and predict a hemispheric infarction. I'm at the University of Minnesota. We are one of 7 centers that is NIH funded for this Human Connectome project. What the Human Connectome project does is it looks at the integrity of pathways in an algorithmic way, and then you can figure out whether or not they're impacted by brain injury. Physical examination would be the next part that you can disrupt and use machine learning on. So you've got things like eye tracking. We've got an eye tracking technology where we measure your eye movements as a person looks at a computer screen. We measure the Cartesian coordinates X, Y of the pupils over time. And we can figure out if someone has restricted vertical movement or horizontal movement. And that tells us if they have a 3rd or 6th nerve palsy. Well, how is that helpful? What we know is that if your ICP goes up, your cranial nerve function is impaired. You get axonal slowing. And so certain nerves are more impaired than others because they have a longer intracranial course. So the 6th nerve is more readily impaired than the 3rd nerve, for example. The 3rd nerve is a much fatter nerve and it's got a shorter course, so it's less impaired. And so we can see decreased horizontal movement of the pupil when someone's ICP goes up. So eye tracking can potentially help us figure out how to quantitate the extent of brain injury. And when you combine it with other measures such as serum markers, so this is a review put together by the TRACK TBI group, one could imagine that you could look at something like even the time course after brain injury, and then you can look at the different types of brain injury, spontaneous hemorrhage, anoxia, diffuse axonal injury, all have different serum marker footprints. Combine that information with genetics. You have about 40 different genes at this point that we know are involved in brain injury. And you put that all together and you build an algorithm. So will we have a single vital sign that tells us what we need to know about brain injury? I would doubt it. I don't think it's as simple as an integer because we're dealing with an organ that is far more complicated than just, than can be relayed in a single vital sign. So intracranial pressure is a great way of conveying part of what's wrong, but it's not the sole factor that determines whether or not someone will have, a different type of brain injury. I think at this point I can take questions.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.